This is part 4 of my facelift series. Today I'm going to talk about facelift incisions. There are probably two major things that people worry about with a facelift. There could be a lot of minor ones. One is, will I look pulled or weird? Of course not. And what do my incisions look like? How do you make these incisions to make them very hard to see from anyone even getting up close? So my facelift incisions heal very, very well. So there are going to be basically two sets of incisions. There are ones around the ears and one under the neck. I'm going to break it down and talk about each one in specific. This is the one that people usually fear because this one's hidden underneath the neck. So with the incision around the ears, let's break it down to in front of the ear and then behind the ear, and talk about, first of all, how long are my incisions? Why do my incisions have to be a certain length? Why should they be shorter than a certain length, etc. So let me first tell you what my incisions don't do. My incision doesn't go up around the frontal tuft of the hair, and next it doesn't go down into the neck of the patient. When you make long incisions down the neck or high up into this temporal tuft, they're the ones that are unfortunately dead giveaways you've had a procedure done. So my incisions are shorter than that. They usually end at the bottom of this temporal tuft, and they end at the top portion before it becomes into the neck area. Why do I make those incisions like that? Have you heard of shorter incisions like S-lifts or very, very small incisions? The simple answer is there's a lot of skin that comes out. And in my video about deep plane facelift and SMAS, I did talk about how skin is actually not relevant. It's not what I'm lifting, it's not what I care about. And when I do a second or third time facelift patient, they may not have a lot of skin removed, but sometimes there's a lot of skin that comes out after the deep tissues are elevated. So as I said, the skin doesn't matter. But what if there's a lot of skin there? What do you do with it? If you make a small incision, you can't remove the skin, and that's really the problem. I've got to get rid of that skin. If your incision is too short, it's going to bunch. So I want my incisions long enough that I can get rid of all that extra skin, but not so long that the scarring looks bad. The other reason I need a longer incision than this tiny little S-lift is I need access. So for example, that posterior limb, not only does it hide well, and not only is it an area that I can take away all that extra skin and distribute it over a wider zone, but also in the areas I can actually access the deeper part of the neck. If I don't make that a posterior limb, I can't get down into the neck area. I don't have access. So those are the two reasons why the incisions have to be long enough. Now, how do I get my incisions shorter than a lot of doctors out there? Why are they not as long as in those areas that are problematic? So the reason is I rotate the skin, I'll tell you what that is, and I control a dog ear through a closure approach. So let me explain that. So the front zone, I do a skin rotation, so I'm able to take that extra skin and rotate it out of the way rather than just going straight up. If I chase a dog ear basically means an area that's beveled up too high, I will have to keep on cutting and go too long to try to get rid of that dog ear. But if there's two ways to knock out that dog ear without having to make a longer incision. So the first method is a rotational method, so the skin gets rotated up rather than trying to chase it all the way down, chase it all the way up. On the back of the ear, what I do is also a rotation method, but also I do a sewing technique. So let me explain. Basic plastic surgery technique is that if one side's longer than the other, there's really two ways to fix it. Method one is just to make that incision longer, chase that dog ear till it goes away, or you can cheat. And the way to cheat is very simple. If there is a longer side and a shorter side, I take bigger bites of the longer side and shorter bites of the smaller side. So I'm stealing millimeter, and I'm distributing that extra length all the way along so I can make it a shorter length to the incision. So that's how I keep my incision short enough, long enough. So that's one thing. Let's talk about incision placement. We'll talk about a female first, which is really what's called post-tragal. So what I do, first of all, is let's talk about universal incisions. For under the temporal tuft, I do what's called a trichophytic incision. So anywhere it's along hairlines here or here, what I do is I do a trichophytic closure, which I intentionally transect one row of hairs. That allows the hairs to grow through the scar. That camouflages in behind the ear coming down and also in this zone right here. The other thing is I make no straight line. So you don't want to make a straight line because if it's straight, I just saw a patient yesterday, she had a straight line going down. A straight line first draws your attention to it. The second problem with it is not how nature looks like. So when I used to do cancer operations where I have half a nose missing, I always made my incisions in areas where your eye would naturally think there would be an incision. So for example, in the front of the ear here, I can't really see my ear, but there is a natural crease that goes down in front of the helix of the ear, which is right here, and I make that incision there. It's curvilinear, nothing is straight, everything is curvilinear, and as I go into the tragus, I make that curved, and then coming down from the bottom of the tragus, this is the tragus with the little part you push when you want to close off sound, down to the bottom of the ear. There's also not a straight line there. I do a little M shape. It's a little modification I came up with because instead of going straight down that exposed area, it actually goes, there's a little M modification. And the connection from the tragus down, instead of going straight down, you want to make what's called a hockey stick, where you just go out a little bit and then down and then rotate it so that that area also has no straight line. With the tragus area, what I'm doing is I'm thinning down the skin. You do not want a very, very thick area of skin sitting on there. It won't look natural. On the back of the ear, I hide it in the crease, and then I also hide it along the hairline using the trichophytic incision that I mentioned, and I avoid going down the length of the neck through the technique I mentioned. The other trick is the sequence of closure, to not take tension on the bottom of the ear. If you look at patients who have had tension on the earlobe, you get what's called a pixie deformity, where it looks like the earlobe is stretched down. It's very simple how to avoid that. What you do is, for 20 years now, having done facelifts, I do the same sequence of closure every single time. I suspend the front, I suspend the back. I trim down the back of the incision, I trim the back of the ear, then, I trim the back of the incision, then I split the lobe, and then I finalize, close the front and close the back and take off this extra skin. So once I've supported the position of where the hairline, where the upper incision should be, I split the extra skin and reveal the lobe. That way there's no weight on that lobe being pulled down, and there's very little risk of a pixie deformity being pulled down. And so finding down, making everything a natural incision where it should be is very key. And the final component of it is making sure that there is no tension on the wound. If you're closing your incision on tension, you're going to have a scar that doesn't heal as well. And so those are the tricks there. For a male incision, it depends on a lot of factors, and that's a whole one. You can listen to my separate video about male facelifts to go in even more detail, but suffice it to say, I either do a pre-tragal incision, and I have some of those photos on my website as well to show you how well they heal, versus a post-tragal incision. How do I make that decision? How do these pre-tragal incisions heal? The pre-tragal means it sits in front of the tragus instead of hiding it in the tragus. I do that if it's, again, no straight lines, all curved in the zones that need to be curved, but I do that if they have a deep sulcus, in other words, a deep bend that goes down, so it's a natural curve point that I can hide it in, or if they've got very thick, oily skin that just doesn't look right on the ear, I won't put it on the ear. Or if they've got a lot of beard that they don't want to transpose because they like wearing a beard, I'm going to do oftentimes a different incision than I would for a standard female incision. For the area underneath the neck, that does take longer to heal, in the sense that that's an area, because it lies external to the facial zone, that can be a little bit more visible even for a few months. But because it's hidden underneath the neck, it's only really visible if someone looked really closely in that area, and but it's an area that typically heals very well. With a deep neck lift, it's a slightly lower, longer incision, but because that incision, if I drew it for you with a very full neck, you're going to think it's sitting on the vertical plane of the neck. It'll be very scary. But once I bring that whole neck up, that incision is tucked underneath the neck, and it looks just like a skin crease. So it heals really, really exceptionally well. So again, this is one of the fears patients have about incisions. I just want to do a deep dive in terms of how I make incisions heal so well. Of course, I've got a lot of before and afters on my websites, even close-ups of incisions, both video as well as static still images.